Hello, Shreya. We are back again.
Yes. Good evening, sir.
Yeah, that's a nice way to greet the examiners in the exams. So you have to say good morning or good afternoon or good evening as appropriate for the day. And I don't have to say that. So let's not time and straight away go to the continued part of the case. Yesterday we discussed whole lot of issues, and today we will
Hmm.
continue with the case, right? So
Yes, yes, sir.
So, what are the types of diagnosis is made in heart disease? What I mean by this is, we know basically it is congenital heart disease or rheumatic heart disease. But in medicine, we were taught different types of diagnosis have to be made. You have any idea about that?
No, sir.
Yeah. Anyway, let me tell you that. So the diagnosis is anatomical diagnosis. It means that where is the lesion? Whether the lesion is mitral or aortic stenosis or aortic coarctation of aorta and things like that. So that is anatomical diagnosis. This is very
Okay.
useful, especially for a cardiothoracic surgeon or an interventional cardiologist to decide on what type of intervention has to be done. So anatomical diagnosis, no matter what is the cause, finally what matters to a interventional cardiologist is the site of the problem. Okay.
Yes,
So that's why
yes, sir.
anatomical diagnosis is important. But from the treatment point of view, what is the cause is important for especially a physician or a cardiologist proper, whether it is rheumatic in origin or whether it is congenital in origin. If it is rheumatic in origin, we know that there is treatment, there is prophylaxis to be given and all that. If it is congenital heart disease, of course, again, a surgery is required or post surgery, we have to give certain drugs. So that is what is called etiological diagnosis. Now, in
Okay.
both of these two types of diagnosis, obstetricians have very minimal role. Okay, we understand this, but we don't have to do much because we are dealing with the patient only for a small window of 9 months, right? So, what
Yes.
is important for an obstetrician is what is called functional diagnosis.
Mm.
In a given heart disease, in a given lesion, how the patient
Yes.
is faring today, how the
Yes, sir.
patient is faring during pregnancy. That is very
Mm.
important for us. And this functional diagnosis is based on, New York Heart Association classification. Okay, I
Mm.
am
Yes.
very sure that you know what is this New York Heart uh, Association classification. Is
Yes,
also
sir. NYHA classification classifies heart disease into four grades. Grade one being that the patient has no limitation to activity. The second grade being that there's slight limitation to unaccustomed work when they're doing exaggerated work. Third grade is when they're having marked limitation to usual work as well. And of course, grade four is when they're having dyspnea or restlessness at rest even.
Yeah, what I'm very happy and I want to tell all the audience who are watching this program is I and Shreya never discussed this case before. We have never rehearsed this. I never revealed the questions to her. There's no match fixing. And I'm very happy that Shreya is answering as though she has snatched my PPT somehow from my computer. She has not done it. Now, because my slides are exactly same what she said, and it is no limitation of activity whatsoever. There are many words, but I have simplified this as this way: no limitation of activity or slight limitation of activity. I'm using the rest of the words same. The highlighted words only you read. And actually, I have added unaccustomed activity. That means for an accustomed activity, it is definitely the person should not have any problem. But unaccustomed activity, suddenly, if she has to do more work that day, she will have slight limitation that amounts to grade 2. And then grade 3 is marked limitation. Even for an accustomed activity, the routine activity, what she was doing all these days, suddenly she feels there is limitation. She feels breathless. That is grade 3. And then, of course, the grade 4 is discomfort even at rest, what we call orthopnea. So she cannot even be comfortable in the resting phase. So this is by and large is a very simple and very important guideline for us to functionally grade the patient. And accordingly, yesterday we have discussed what to do how to counsel the patient. Suppose she's grade 1 and 2, she can not only conceive, she can continue with the pregnancy. Whereas if she's grade 3 and 4, we should treat her first, and then only once she is totally compensated, she can become pregnant. Or if she is grade 3 and 4, we have to stabilize her, and in first trimester we go for MTP. In fact, yesterday I forgot to highlight one point. If I remember your first slide, she underwent MTP last time, isn't it?
Yes, sir.
In her first
Yes, sir.
pregnancy, she underwent MTP, probably because she was having already grade 3. Of course,
Yes, sir.
you do MTP after stabilizing the patient, not when the patient is in grade 3, right? Because
Yes.
you,
Yes.
because even if you stabilize now, she may again go into grade 3 or 4 as the pregnancy advances. Probably that's the reason they last time did the MTP, and subsequently she
Mhm.
underwent angioplasty, and this time that's why she has never gone into grade 3. Okay. So
Yes, sir.
now, functional grade is important as for the reasons which I said already yesterday as well as today. I want to repeat. The grade worsens as the pregnancy advances, and it further worsens in labor. That's why if she's already grade 3 in pregnancy, she's sure to become grade 4 in labor, and probably she will have a very bad cardiac failure immediately after labor for the physiological reasons which we explained yesterday. Now,
Yes, sir.
the NOH grading is all right, but it does not talk about what type of heart lesion the patient might have. That's why this
Mm.
Canadian association has come out with what is called CAR-PREG score. Do you have any idea about that? Or before
Yes,
that,
sir.
any risk assessment, the mild risk, moderate risk, and severe
Mm.
risk? Do you have any idea?
Yes, sir.
Yeah.
When depending on cardiac lesions, we have categories of mild, moderate, and severe for risk assessment for mortality of the patient. In case of mild lesions, the mortality risk is less than 1% and includes lesions like small ASD or VSD, mitral stenosis with NYHA grade 1 or 2, patent ductus arteriosus, trivial mitral valve prolapse, or corrected phallus tetralogy. Second one being moderate, which has a mortality rate of 5 to 25%. It includes mild to moderate aortic stenosis, uncorrected phallus tetralogy, Marfan syndrome with normal aorta, moderate to severe systemic ventricular dysfunction, coarctation of aorta, or artificial valve. And lastly, we have the severe category, which has a mortality rate of 25 to 50% and includes severe aortic stenosis, pulmonary hypertension, Marfan syndrome with aortic involvement, coarctation of aorta, which is complicated, history of peripartum cardiomyopathy, and any condition which has an NYHA grading of 3 and above.
Yeah, it's an exhaustive list, but how to make it very simple and remember in a simple way is that, as you can see here, the lesions are almost similar. The only thing when it becomes moderate to severe, there is a complication. For example, you can see that Pallas tetralogy in the mild grade, but it is a corrected one. Whereas in the moderate, coarctation of aorta is there, but in severe, it is a complicated one. Similarly,
Yes, sir.
peripartum cardiomyopathy, if she had. And as far as NIH grade is concerned, it is grade 1 and 2 in mild, it is grade 3 and 4 in severe. So
Yes.
this is called risk assessment. If you know this beforehand, it becomes easier for us to manage the antenatal situation. So now let us
Yes.
talk about Carperic score.
CAPREC score, sir, is a new Canadian score which combines NYHA grading along with the symptoms of the patient. There are four primary events that we need to focus on. One is if the patient has NYHA grade more than 2 or presence of cyanosis. Second being if the patient has a prior history of arrhythmia, failure, transient ischemic attack, etc. Third being a patient having left heart obstruction, wherein the mitral valve area can be less than 2 centimeter or the aortic valve area can be less than 1.5 centimeters square. And lastly, if the left ventricular ejection fraction is less than 40%, then all of these events are included in CARPREG.
Yeah,
According to these events,
yes.
we give a scoring about for the patient. So if none of these four categories are present, then the risk of cardiac event in that patient is 5%. And if one of these four categories is present, then it is 25%. And if two or above is present, then the risk is approximately 75%.
So the advantage of this scoring is that it is combining NYHA as well as what type of lesion is there, right? So
Mm.
It
Yes.
includes congenital heart disease as well, and acquired heart disease, both of them. So that's why it's again not very complicated. It looks complicated, but it is not complicated as such. So it is, as you can see in the previous slide. So NHA 1, I mean 2 or more with cyanosis is just 1 point, and then the person already having cardiac failure or a left heart obstruction or a reduced LV function. Ultimately, the cardiologist will look at the what is the ejection fraction. So, given whatever may be your lesion, but your ejection fraction is lower, then you are actually at a risk for cardiac failure or even heart failure. So that is
Yes.
where this score is now becoming more popular, but we can still stick to the NIHA classification, which is very, very simple. Okay. So now
Yes,
there
sir.
are some drawbacks of this. It excludes Eisenmenger syndrome and pulmonary artery hypertension. Okay,
Hmm.
let's continue now.
Yes. Case history. At 31 weeks of gestation, patient complained of cough associated with sputum production. There was no complaint of fever, breathlessness, easy fatigability, or paroxysmal nocturnal dyspnea.
That
Chest
means
X-ray.
probably she doesn't, that problem was not related to cardiac failure. It is a totally different
Yeah.
problem.
Yes, sir. Then, just to be on the safer side, chest X-ray was done with abdominal sheet, which was normal, and
Do you
sputum
think this
culture
one X-ray
sensitivity.
is going to harm the patient or the fetus?
No, sir.
Not at all.
According
Yeah,
to
not at all.
uh,
Yeah, even in the first trimester, one
hmm,
exposure is not really going to matter any much. However, the patients get very much worried. Anyway, here we
yes.
had shielded the abdomen. Okay.
Yes. Yes, sir. Then sputum culture sensitivity was done, which was sterile, and she was noted to be a patient of upper respiratory tract infection, and she was conservatively managed with antibiotics and nebulization.
Yeah, so this is very, very important because as we mentioned yesterday, infection is one of the pathological factors that will push the patient into cardiac failure, and it has to be aggressively treated. So
Mm.
I'm very happy that this was recognized early and it was treated. Okay, continue.
Yes, sir. Serial growth scans for Dopplers were done, which showed a falling trend in interval growths, but normal Doppler findings were noted. Growth scan at 37 weeks was done, which showed a cephalic baby of AFI 14.2 and EFW was 2.3 kg, which
Yes.
was characterized
So this is
like late
again
on.
an expected complication which you mentioned very beginning of the case discussion yesterday, that among the fetal complications it is preterm labor, FGR, and IUD, and probably asphyxia are one of the four important complications. In fact, if you look at it, blindly you can answer these four for any complication in pregnancy. If you are asked
Mhm.
the same question in preeclampsia case, the fetal problems are same: preterm labor, FGR, IUD, and asphyxia. So
Mm.
we have to actively look for this. And the only way to actively look for this is serial growth scan. And we have
Mm.
definitely picked up here. At 37 weeks, we expect definitely more than 2.5 kg, isn't it? So here the
Yes, sir.
baby is definitely falling short, and it is a late onset because in yesterday's slide, there was appropriate growth in the initial part, the
Mm.
first growth scan when
Yes.
it was done. So it is a late
Yes.
onset. What do you mean by late onset FGR, if I can ask you?
Yes. Late onset FGR, if FGR develops beyond 32 weeks of gestation,
Yes,
that
that
is
is
called late onset.
okay. So like this examiner will just jump from one case to another because in obstetrics, you should know everything. You cannot say, I got a case of cardiac disease and the examiner was asking me about FGR because everything
Mm.
is mixed here, isn't it? So
Yes.
anyway, I'm
Yes, sir.
happy to note that you could answer this question. And this particular patient, the Doppler parameters were normal. That means there was no impending problem for the fetus, except that the baby was having FGR. This point is very
Yes.
important to decide the timing of the delivery, which we will discuss little later. Okay,
Yes,
so
sir.
going ahead,
Coming on to the past history, the obstetric history patient first conceived in 2022, and at 20 weeks of gestation, patient had complaints of breathlessness, and at which time she was diagnosed for the first time with rheumatic heart disease, wherein she had developed features of decompensated mitral stenosis. Hence, she underwent induced vaginal expulsion for the
yeah, this
same.
is what we have been discussing yesterday, and even today we mentioned that this particular patient, because she already was, I mean, decompensation means grade 4. She was almost in the grade 4. And that's why even in second trimester of 20 weeks, they took a decision to do MTP because, as I said, the risk of continuation of pregnancy as well as MTP is same. So it depends upon an obstetrician. Either way, you can decide, and both are right or both are wrong. So, but one thing is definitely they took care of the patient. And if you remember, as you were saying, I was noting that this is the first time patient also came to know that she was having the cardiac problem. That's a tragedy.
Yes,
That's why probably, when she was first had an antenatal checkup, somebody should have put a stethoscope on the chest. They would have probably diagnosed mitral stenosis. The diastolic murmur is an obvious one. Okay, so
yes,
again highlighting that the every single patient in the first visit, we have to, in the first pregnancy especially, we have to put a stethoscope on the chest and find out whether there's any cardiac problem. Because sometimes when you ask history, patient may not know, right? Patient may not tell. All right. So medical history,
yes,
of course, same thing. She underwent
yes.
ballonotomy. And family history, nil significant. You have written. What would be my comment? I have some
The
objection for this.
the significant history that we can ask in the family when we are pursuing a patient of cardiac disease in pregnancy, if there's any history of hypertension or if there's
Yes.
any family
Yeah.
history of congenital heart
Yeah,
diseases.
many examiners object for this because if you simply say nil significant, there are two possibilities. One is you don't know what to ask, simply you say nil significant. All right. Other one is you
Yes.
asked specifically for certain problems and you found out that they are not there. So you must show
Hmm.
your, intelligence to the examiner, saying that I did ask for hypertension, I did ask for history of diabetes, I did ask for history of any congenital or heart disease which is running in the family, and I did ask
Hmm.
for a history of fever and other things in the, rheumatic heart disease has a history, isn't it?
Hmm.
So, but anyway,
Yes, sir.
that comes under personal history, but family history, you have to specify, especially in obstetric case, that I did rule out diabetes and hypertension. Okay. All
Yes.
right. I'm
Yes,
just,
sir.
just, I'm happy that you just put it nil significant. I didn't correct it. So I wanted to bring this issue. Okay.
Yes, yes, sir.
Okay.
No personal history of allergies. She consumes a mixed diet and sleeps well.
Sleeps well means there is definitely no PND, isn't it? Yeah.
Yes, sir.
Coming to general
Coming
physical
on.
examination.
Yes, sir. The patient is a thin, poor-built female with a BMI of around 18. Her presenting vitals were
Is it
stable
good or
with a
bad?
pulse rate of BMI.
Hmm. This patient's for this particular situation.
No, I mean that low BMI is not good for any patient,
No,
but
low, yeah, I agree that, if you start with less than 40 kg, then there will be problems of, fetal IUGR, small baby, and all those things. But considering that she's a case of heart disease, high BMI is also not good.
yes, sir.
Obesity is also not good. Okay.
Yes, sir.
Yeah.
Yeah. The presenting vitals were stable with a pulse rate of 86 beats per minute, but BP of 110 by 70 mmHg and SpO2 of 99% on room
Yeah,
air.
I may just accept this, but some examiners, especially if you get a cardiac case, they would expect little more things to be told in, PR, pulse. You should not only say 86 per beat per minute, you should say good volume or what volume, and all those things you have to talk. Okay.
Okay, sir.
Yeah, yeah,
No. No pallor, edema, clubbing, or cyanosis noted.
yeah. So, and thyroid breast
Thyroid and
examination
breast
is normal.
examination
Yeah, there is no,
normal.
some people, some examiners would expect no thyroid enlargement to be told.
Huh.
And because you can't
Okay.
say thyroid normal just by looking at the thyroid, right? So
Yes. Huh.
better answer would be there is no thyroid enlargement. Okay. So, and then
Okay.
breast examination, of course, there is no anything obvious. Especially what would you look for in an obstetric case? Breast
In
examination.
obstet
Any retracted
in
nipples or any secretion, especially frank milk coming
hmm,
prematurely, suggests that she is probably going in for
mhm.
delivery, or sometimes
La-
one of the patients of, it's
yes.
one of the signs in a IUD, intrauterine
Yes,
death.
sir.
So you have to
Hmm.
simply say normal, sometimes may not mean much. You have to specify.
Hmm.
Okay. Yeah.
Yes, sir. On CVS examination, normal heart sounds were noted S1, S2, and no additional murmurs were noted for the
So that
patient.
means the balloon angioplasty has worked out so well. There is no murmur at all, residual murmur at all. Okay,
Yes.
should I take that way? Okay. I would believe you
No.
now because I didn't have an opportunity to examine the patient, but sometimes examiners will definitely go and auscultate. So you have to be doubly
Yes.
sure that there is nothing heard now. Okay.
Yes, sir.
All right.
Hmm.
Good.
On respiratory examination, normal vesicular breath sounds noted, no crepitations.
No crepitations means there is no chance of her having
Edema, pulmonary edema or congestive heart failure.
cardiac failure right now. Okay. Okay.
Yes,
Obstetric
yes.
examination.
Obstetric examination and inspection, the abdomen was uniformly distended, no scars noted, umbilicus was central and everted. On palpation, the uterus corresponds to 36 weeks of period of gestation. Symphysiofundal height was 36
So
centimeter.
there is definitely a lag of at least 2 to 3 weeks here because you said she was
Yes, sir.
38 plus, if I remember correctly. So
Yes, sir.
this suggests that there is a lag. That means there is a late onset FGR in this particular case. But anyway,
Yes.
you could appreciate the fetal parts and fetal movements you could have written because fetal parts will be definitely obvious. That means if it is very obvious, then it is oligohydramnions.
All-
But anyway,
Yes, sir.
what about fetal heart rate? Yeah, it's regular.
The-
Okay.
yes, sir.
So that completes your obstetric examination. Now we have to come to the management of it. So before
Yes.
we go to management of this particular case, because it's a first case in our first case discussion series, I want you to tell broadly classify the management of any obstetric case first, because what I firmly believe is that obstetric is very simple management. Actually, there are only 4 questions in obstetric management, and these 4 questions come up in every single case, no matter whether it's a heart disease or a preeclampsia or a diabetes or anemia or any other case. And this is the chapter which I wrote first. It's hardly 1.5 page chapter in Holland and Bruce, fourth edition. And this actually impressed the people of Elsevier's. And I think all the students should read this particular chapter. I will share these 2 pages to everybody. Can you just elaborate on that?
Yes,
What are
sir.
the four
For
questions?
obstetric, yes,
Yeah.
sir.
Yeah.
For obstetric management, in case of a
Usually, there
patient,
will
we
be three
first,
parts in a management of any case, isn't it? First is
yes,
managing the
yes,
medical condition. In this particular case, it is heart disease. Second one is
yes. We
prevention,
have to
prevent the
our treat
or treat the complications.
complication.
Yeah. Whether it is heart disease, in heart disease, of course, it is prevention of cardiac failure and treating cardiac failure. In a case of preeclampsia, what do you want to prevent?
Eclampsia.
Very good, simple as that. Or if eclampsia occurs, then you have to treat it. In a case of
Yes,
anemia,
sir.
again, what do you want to prevent? Anemia.
Um,
There's nobody next to
uh,
you to help you.
no, sir.
Okay, no problem. It's again cardiac failure. Okay,
Hmm.
it's again cardiac
Yes.
failure. Anemia will lead to cardiac failure. In a case of diabetes, what do you want to prevent?
Mm. IUD,
Ketoacidosis. Okay, ketoacidosis,
ketoacidosis.
sudden IUD, and macrosomia, and things like that. So, in other words, what I'm trying to tell everybody is that the management is mainly 3 things. Number one is management of the problem. Here it is heart disease. In diabetes, it is diabetes. In anemia, it is anemia. In preeclampsia, it is hypertension. The second aspect is prevention of complications due to this medical problem. And the third one is obstetric management. And I told you,
Hmm.
obstetric management is simple and straightforward in every single case. There are 4 questions. What are the 4 questions?
The 4 questions that we need to ask in an obstetric management is
Yeah,
first, when to deliver the patient.
yeah.
We need to know if we need to deliver at term or at what gestation. The second being how to deliver. Now, once we have decided whether we want to do a vaginal delivery or we want to do an LSCS. Third question being, in case we have decided upon a vaginal delivery, whether we should wait for spontaneous onset of labor or we should go ahead with induction. And fourth being, if we have decided to induce, at through what agent do we need to induce labor?
Okay, so these are the 4 questions. You take any case, they will come. First and the most important, $1 million question. in any case for any obstetrician is when to deliver. One who knows when to deliver is a master. Okay. Second one, of course, how to deliver. We have only two routes, fortunately. One is vaginal route, other one is abdominal route. This is, of course, also can be a very important question. The third one is actually, if you have decided to give vaginal delivery, whether to wait for spontaneous onset of labor or whether you have to induce the patient. And only if you decide to induce, the fourth question comes up. Otherwise, the fourth question does not come up. So let's go back to our original uh, case, that is how to manage the heart disease. Okay.
Yes, sir.
As I told, 9 months is a too short a period for obstetrician to handle. However, our role is to ask the or request the cardiothoracic surgeons whether they should intervene. So, what are the indications for heart surgery during pregnancy?
The indications for heart surgery include if there's severe mitral stenosis where the mitral valve area is less than 1 centimeter square, or if the patient has had repeated episodes of congestive heart failure, or in case she fails to respond to medical line of management, or if she has arrhythmias with pacemaker, then we need to go for a surgical management during
And of course, the best time for surgery is second trimester. It is considered
that.
as the stable time, isn't it? Even
Yes,
then,
yes, sir.
cardiothoracic surgeons, they ask us to be in the OT and monitor the fetal heart rate. And they want us to tell whenever the fetal heart rate goes down, they may stop the procedure temporarily and they may ask the
Yes,
anesthetist to just, do certain changes, change the position of the patient and give oxygen and things like that. So this is by and
hmm.
large is the management of the heart disease. And of course, if the patient is on any what do you call the prophylaxis, we have to continue the prophylaxis. And
Hmm.
penicillin, a group of drugs are not at all contraindicated even in first trimester. So we have
Yes, sir.
advantage there to continue. And yesterday already you have talked about the anticoagulants, how to switch over in the first trimester to second and then back to the same in the third trimester. So that and all we have
Yes.
already discussed. As far as surgery is concerned, the best type of surgery is balloon valvotomy is the best.
Valve.
Yeah. So how to prevent the complication?
In order to prevent the complication, first, like you said, sir, we have to give penicillin and continue penicillin throughout the pregnancy, even the first trimester. And secondly, if the patient is undergoing any additional surgery or dental extraction or etc., we need to give additional chemoprophylaxis to the patient. And thirdly, we need to avoid any risk factors, as we have already discussed yesterday, like infection or anemia. And in case they do develop, we need to aggressively treat it.
Yeah, in this particular case, we saw that at 31 weeks, she developed upper respiratory tract infection and you have aggressively treated it with antibiotics, even though the sputum showed sterile. That is questionable. Maybe sometimes, the sputum will be sterile, but if you do different type of microbiological examination, nowadays, the cultures, we don't depend only on culture sensitivity, right? So we can
Yes.
give antibiotics and we have to treat it aggressively. And they have to also avoid undue exertion and stress. In fact, I remember one of my professors used to say they should avoid crowded places. They should avoid going to movie theaters because somebody will be infected there and you will pick up the infection, right? So these are
Yes.
some of the things we can do for prevention. And then, of course, in that uh, mindset, we should have also admission policy firmly defined. So, what is the admission policy in the case of heart disease?
For in case of heart disease, it is depending on NYHA grading, sir.
Very
For a
good.
patient with NYHA grade 1, it is a patient with who does not have any complaints, so can be treated like a normal antenatal patient.
Yes,
So we just have to admit them at term when we have to deliver them.
yes,
The second NYHA grade 2 patient needs to be admitted at 28 weeks of gestation
yes,
because A, we need to look for signs of congestive heart failure and we
yes.
need to give steroid prophylaxis in
Yeah.
these patients because they
Very
have a tendency to
important,
go into
pertinent point you have
preterm
brought here. In addition to knowing that this is the time they may go into cardiac failure, the second important point you brought out is that we need to give steroid prophylaxis because all these high risk patients, we need to give steroid prophylaxis. Okay, good.
Yes, sir. And then a patient with grade 3 or 4 NYHA, they have to be admitted as soon as they're diagnosed.
Yes,
They
this
have
is
to be
what we have told
convinced for
yesterday, and
hospital.
they have to be kept throughout the pregnancy and even 14 days after the delivery. Right. What are the reasons for emergency admission?
In case of emergency admission can happen for a patient in case we notice that they have tachycardia, which is going more than 100 beats per minute, they're developing arrhythmia, or there's any deterioration of functional grade, or if they're getting signs of dyspnea, basal crepitation, or any other complication like congestive heart failure, pulmonary edema, etc., then we have to immediately admit them on an emergency basis.
Yes, irrespective of the gestational age. Okay. So
Yes.
obstetric management, we have discussed these 4 questions. Now let us try to answer these questions. When to deliver? When to deliver,
Uh,
even though it's a $1 million question, there is always a default answer for every question. What is the default
mm,
answer for when to deliver?
term a patient whenever we want to deliver every patient at term,
Yes,
and
very good.
so
Nowadays, we don't even say, you know, that term is further divided into early term, full term, and
yes,
late term. So
late
why
term.
I have written here 39 weeks? Can you tell me? Preferably 39
Mm,
weeks I have put. This is a general answer, not for this case.
yes, sir. Because the patient, the baby is mature and
Baby is mature at 37 also.
mm,
That is why the
but
recent classification 37 to 39 is considered as early term. And this time, it is the baby behaves same as late preterm, that is 34 to 37. Whereas after
okay,
39, the incidence of RDS, that is respiratory distress syndrome, is almost zero. So that's why
okay.
preferably 39 weeks. This is a general answer, but we have to modify the answer earlier
Mm,
if there are complications like imminent eclampsia, abruption, or any other situation. Okay. Second question,
yes,
how to deliver? There are only 2 routes.
yes, sir. Either vaginal route or
Yeah. What
LSCS
is the
route.
default answer?
Vaginal route is the
Yes.
default
Default answer
answer.
is vaginal route, preferably because unnecessary cesarean section should be avoided. However, we should not hesitate to do section if there is a problem
Mm,
with passage, passenger, or power. I don't want to elaborate right now. Okay.
mm,
Then
mm.
whether to wait for spontaneous onset of labor or should we induce? What is the default answer?
Spontaneous onset of labor
Yes,
is the
default
default
answer
answer.
is yes, we have to wait for spontaneous onset of labor. Again, what is the rider? Unless
And
there
unless
are
there are other
complications like
complications,
preeclampsia,
maternal or
GDM.
fetal.
And the last question
Yes.
arises only if you have decided to give vaginal delivery and to induce. And how to induce? Of course, it depends
Uh,
on
Bishop score. So
before that
depending
engagement of head. Don't induce a
engagement.
patient with mobile head. You will end up with
Mm,
problems, right? And then, of course, favorability of cervix, as you said, Bishop score. And then finally, if there are any
con-
contraindications for induction. Okay. For example, in heart
yes.
disease, the
Mm,
oxytocin induction, of course, nowadays we don't induce with oxytocin at all. We have given it but long back. Okay. But
yes,
the
sir.
prostaglandins are not at all contraindicated here. But
Mm,
again, other methods like putting bougie or putting Foley's catheter is contraindicated because of the fear of infection. Okay.
infection.
Now let us apply this formula of 4 questions to our case. Okay. Now,
Yes, sir.
when to deliver this patient?
Uh, Cardiac disease in itself is not an indication for preterm delivery. So we
Very
want,
good.
if it is possible, we
Very good.
want to
In
push
fact,
to 2
preterm
months.
delivery happens all the time and we have to stop it or prevent it. And we can wait
Mm,
comfortably at 37 completed days. But your particular case, already she has crossed 38 and there is FGR,
mm,
probably she should get into labor
mm.
soon. Okay. How to
Yes.
deliver
Yes.
this patient, cardiac patient?
Uh, a cardiac patient preferred mode of delivery is vaginal route.
Correct. Again, just
LSCS is
because she has
only
got heart disease, you don't have to go and do a cesarean section.
mm,
Very good. But what about your
yes.
patient?
For my patient.
Hmm.
Same, sir.
Yeah,
Vaginal route
yes,
is
your
okay.
patient is, of course, she's having IUGR, but it is not so bad yet. You know, it is
Huh.
very 2.3, 2.4 kgs, good for vaginal delivery. Whether to wait for
Yes,
spontaneous
sir.
onset of labor in your case, cardiac case?
Yes, sir.
Yes,
We
of
prefer
course.
to wait for.
We can, we are. There is, in fact, induction is not at all called for. In fact, if you say induction,
Mm,
then you will be stuck. How to induce our
mm,
complications and all those things.
mm.
So,
Yes.
and what are the indications for cesarean section in a heart disease?
If the patient has aortic aneurysm or coarctation of aorta, those are the two big indications wherein we directly go for an LSCS in a heart
Exactly.
disease patient. Other than
and
that, we have aortic dissection, aortopathy with aortic root more than 40
and
mm,
Marfan
Marfan
syndrome.
syndrome.
Yes. Okay.
Yes,
So
sir.
arrhythmias. So of course, then obstetric indication is there for everybody. We let us not have to worry about it. If there is severe FGR, extreme prematurity, malpresentation, fetal distress, whether it is cardiac case or not, we are going to do. So as I said in the second point, if you can see, if this patient were to be less than 4,500 grams or less than 34 weeks, then maybe cesarean section, otherwise not required. Labor management is
Yes,
very
sir.
important. Okay.
Mm.
What are the things you should remember? We should keep
For
anti-failure drugs
anti,
ready. What are they?
yes, sir.
Oxygen,
Uh,
pethidine, digoxin, and diuretics. If you
hmm.
don't have that, what will you do?
We will refer the patient to a tertiary center, sir. We
Wow, you
have to.
snatched my dialogue. You're right. Better to keep it in your hospital, but if you don't have, don't hesitate to refer the patient to a higher center, okay, instead of losing the patient. Then, of
Yes,
course,
sir.
you have to avoid lithotomy, better to put in propped up position. You can always give the oxygen to the patient. Avoid fluid
Mm.
overload. Unnecessary
Mm.
don't give. Keep a catheter ready, maybe, or I mean, line ready, but don't have to give fluids.
Mm.
Hemoprophylaxis, this is debatable. Most of the cardiologists say no need to give for simple cases. Only
Mm.
complicated cases you can start in active labor. Active labor is 5
Mm.
centimeters now. Okay. And then, of
Yes, sir.
course, this is very, very important. Cut short the second stage by outlet forceps so that patient doesn't have to strain much. Now, there is a debate
Mm.
whether we can apply vacuum or not. The modern vacuum is you can quickly attain the vacuum. That's not the issue. Issue is in vacuum, patient has to strain. Whereas in forceps, patient doesn't have to strain at all. That's why
Mm.
we all have to develop the skill of outlet forceps at least. It's very easy, not at all difficult. You can learn on the
Yes, sir.
mannequin also, right? And then,
Mm.
of course,
Yes,
we
sir.
have to avoid ergometrin, but active management of third stage of labor is not contraindicated. If I remember
Mm.
correctly, reading Davidson, there, one of the treatments for congestive cardiac failure is letting the blood go. The venous section
Mm.
used to do,
Yes.
but in the modern Davidson, it is not there. So some
Mm.
amount of postpartum hemorrhage is not bad for this patient. At the same time,
Mm.
we cannot say I didn't allow the patient to die of heart disease, but I allowed the patient to die of postpartum hemorrhage. That kind of situation should not be there. Okay. All
Mm.
right. So, but
Yes.
active management of search of labor is welcome.
Mm.
Postnatally or immediately after delivery, what you should do?
Post
Will
delivery,
you
we
go and
have to,
congratulate the
because
patient party that congratulations you delivered and all that, or will you stay back with the patient?
we have to stay back with the patient
Yes.
because the
Why?
immediate post delivery,
Yes.
because immediate post delivery period is also a time when suddenly a lot of load is going to go on the heart, so the
Yes.
patient
That's
might
what we
go.
yesterday told so well and so nicely, and we cannot run away from the patient today, right? So we have to closely
Yes.
monitor the mother as well as the fetus. Sometimes you can use electronic fetal, continuous electronic fetal monitoring. And immediately after the delivery, stay next to the patient, monitor her pulse, BP, everything, because she can go for congestive cardiac failure at that time. And postnatally, treat infections very aggressively because she can have anemia now and lot of infections. We cannot relax now. Tubal ligation, if you have decided, you have to do it after 1 week, not after 2 days, as in other cases. And when will you discharge the patient and why? 14 days?
Because the patient, like we said yesterday, more approximately till 7 days, the patient has a
Yes,
tendency to go
there
into
will be
CHF.
problems. So, better to make sure that everything is fine. Conventional contraceptives only to be used for spacing. What are the
Mm.
common causes of mortality? Last few questions, last minute. Any idea? Have you heard of
Common
this rule of
cause,
five?
no,
Okay,
sir.
let me tell. In 5 minutes, pulmonary edema and acute rheumatic
Yeah.
carditis. In 5 hours, cardiac failure. 5 days,
Mm.
bacterial endocarditis. 5 weeks, thromboembolic phenomena. 5 months, peripartum cardiomyopathy. So you have to be very,
Mm.
very careful. So thank you very
Mm.
much, Shreya. I think you have done extremely well. Maybe one or two
Mm.
questions you were hesitating to answer. That doesn't matter. You are still 1 year to go, and I'm sure you will do well in the exams. One thing you can avoid is that you were sort of giggling when you didn't know the answer. Some examiners take it in a right spirit.